Welcome to the second part of atrial septal defect. Now we have this classification based on the size of the defect. Small defects are categorized if they have the size less than 3 mm, moderate are from 3 to 8 mm, whereas large defects are more than 8 mm. Usually they are associated with certain other diseases, like in the case of uh, secundum ASD. They might be associated with pulmonic stenosis, mitral valve collapse, partial anomalies of pulmonary venous collection, primum atrial septal defect may be associated with cleft mitral valve, discrete subaortic stenosis, sinus venous septal defect may be associated with partial anomaly of pulmonary venous return, whereas coronary sinus septal defect are associated with partial and total anomalous pulmonary venous return, persistent left superior vena cava. Now the signs and symptoms associated with this defect. Usually small defects are asymptomatic, and it is only during the routine checkup that they do come to your notice. Whereas large defects are symptomatic and patient will present up with failure to thrive, that is their survival is difficult as they do have less amount of oxygen circulating in their blood. They get easily tired, that is fatigability is quite easy, increased perspiration, recurrent pulmonary infections, platypnea and orthodeoxia. On examination, generally the appearance is usually normal, heart rate is normal, respiratory is normal, and height to weight may be less than the 10th percentile of the examination. So appearance is usually normal, heart rate and respiratory are normal initially, but as exertion is brought about, we get different readings of heart rate and respiratory rates. Now, how do we have an inspection? That is, that we find a slight prominence in the precordium region. Palpitation apex may be beat may be shifted to the left. Second, P2 may be palpable, and a left parasternal heave may be present. Now, about the auscultation, that the type of sounds that we listen, that is, S2 is widely split and S1 is normal, that is the first sound is normal usually, and S2 is widely splitted and fixed. So, we get a disruption in the second heart sound. Ejection systolic murmur is also heard, which is medium pitch, soft, grade 1 to 3 sound, and best heard at the second and the third intercostal space. A diastolic flow rumble across the tricuspid valve region is also present, and we have seen into the reasons why we have this ejection systolic murmur and diastolic flow rumble. Now about the investigations, we have a routine test of CBC, septic screening for any sort of infection, serum electrolyte, serum creatinine, blood grouping, coagulation profile, etc. And the diagnostic investigation include X-ray, ECG, echocardiogram, and sometimes cardiac catheterization, where in X-ray we find cardiomegaly, where we have right and left ventricle enlargement, full pulmonary conus, increased pulmonary vascular markings, and plethoric lungs. Is full of blood because we have extra blood flowing into the pulmonary circulation. Now the important part about seeing into the ECG. The first thing is that we have enlarged P wave, which usually indicates a right atrial hypertrophy. Also, the R wave that would be tall and which would be indicating right bundle branch blockage and right ventricular hypertrophy. Also note that as the AVF node is predominantly upward as compared to the lead one, indicating right axis deviation. So the major findings are the enlarged P wave and tall R wave. Now for the associated lesions, right atrial and right ventricular enlargement with diastolic flattening and paradoxical IVS motions are evidence of right ventricle volume overload and a significant left to right shunt with mitral valve prolapse, cleft mitral valve, and enormous pulmonary vein emptying. Contrast electrography with intravenous agitated saline may be used to confirm the presence of a shunt if color Doppler are not conclusive. Echocardiogram is a primary diagnostic imaging modality for atrial septal defect, which provides us exact localization of ASD, size of ASD, measurement of septal confirmation of the shunt, abnormal motion of ventricular septum, and associated lesion can also be identified by echocardiogram. Most children with ASD remain active and asymptomatic. Rarely, congestive heart failure can develop in infancy, but it will later on come in as the age progresses. If untreated, pulmonary hypertension may develop during or after the third decade, and reversal of shunt may be rare. It may be progressive with the pregnancy. So, reversal of shunt, Menger syndrome may also develop. Infective endocarditis does not occur in patients with isolated ASDs. Cerebrovascular accident resulting from paradoxical embolization through an ASD is rare complication. Mitral stenosis may occur as a result of rheumatic fever in case of ASD. So that is what we call as Gluten-Becker syndrome. That is association of ASD with mitral valve stenosis as a result of rheumatic fever. Now for the complications, we have right side failure, recurrent pulmonary infections, paradoxical embolism, mitral and tricuspid insufficiencies, atrial arrhythmia may also be seen. That's it for ASD. Thank you.